Hello, welcome everyone. Thank you for joining us today in our sedation webinar. My name is Vivian. I have a team of anesthesiologists, clinical psychologists, nursing expert, and play therapy in today's section. So my name is Vivian Yuan. I'm the lead and moderator of this webinar. I am a consultant at the Department of Anesthesiology and Perioperative Medicine of the Hong Kong Children's Hospital. I'm a specialist in pediatric anesthesia with special interest in pediatric sedation, that's medetomidine use in children and use of TCI in children. Today, our webinar is on the mind, the mass, and the team. Next level pediatric sedation. So when you look at the topics and the lineup, you might ask, why do we have so many different people, so many specialists of different profession in this pediatric sedation webinar? The answer is that our field has completely transformed. We have evolved past the old days of simply asking what drugs, what dose, when we want to do a procedural sedation, to now we learn the hard lessons that safety should be our priority, but also pediatric sedation has become a comprehensive patient-centered service of its own. So the evolution didn't happen by accident. It was driven by research, communication, and most importantly, teamwork. Over the next 90 minutes, we are going to explore how integrating clinical psychology, play therapy that allow us to minimize trauma and anxiety, continue to refine our use of sedative. We also dive deeply into the pharmacology, looking at how advanced PKPD research continue to refine our use of sedative. And finally, we will be all together looking at the absolute backbone of our success, the indispensable leadership and care provided by our nursing team. Let me introduce our other moderator, Dr. Vibha Nakis from India. She is a senior consultant who works in oncology or cancer hospital in India. She works at the Basa Taraka Indo-American Cancer Hospital, and she also worked in the Research Institute of Hyderabad in India. She's the past secretary of ASPA. She's the editor of IPA and the ex-con member of SOAPC as well as ASPA. So her interest in pediatric onco anesthesia and vascular access. Welcome, Vibha.
Thank you. Thank you so much, Vivian, and good afternoon, good evening to everyone who's logged in. A very pertinent topic, like Dr. Vivian said, and whether we are pediatric anesthesiologists or a generalist, pediatric sedation does come our way. So let us learn together in this webinar today. But before we start, I would just wanted to give a few housekeeping rules. We would really love to have you all interact with us, but we have disabled the chat and raise hand function, and you can do it through the Q&A. You could see the Q&A section at the bottom of your screen, which you can use to send in questions and even comments. Our moderators are going to pick up the questions, and we also have a facility for polling. When the poll, So some of the questions we would like to answer live, while some of the questions we would try and reply it there and then in the Q&A box. Regarding polling, we have a poll which we would want all of you to participate in. And once the poll is over, please remember to use the close button to close the poll. Now, a disclaimer that the information presented in this webinar is intended for educational purposes, not meant to be a substitute for professional medical advice, diagnosis, or treatment. and the views expressed in the presentations are those of presenter, and do not necessarily reflect the opinions or policies of any institutions or organizations that they are affiliated to. So, also wanted to say that the certificate of attendance will be available to all those who are attending this webinar after you've submitted the post-webinar survey. And this survey will be emailed to you tomorrow at the same time. Please remember to key in your full name and email address. And now, very happy to introduce to you all our first team of speakers from Hong Kong Children's Hospital, Vancy Kwok, who is consultant anesthesiologist at Hong Kong Children's Hospital. She's also the course director and organizer for the pediatric sedation course. And her interests are pediatric pain, pediatric sedation, well-being, and training. Welcome, Dr. Vancy. Along with her, we have today Connie Poon, who's a clinical psychologist at Hong Kong Children's Hospital. And she's an international member with the American Society of Clinical Hypnosis. And her interests are clinical psychology, procedural anxiety, pediatric pain, clinical hypnosis. Welcome, Connie. And the third speaker from Hong Kong Children's Hospital is a senior certified child life specialist, Yet Tam. And her experience is she works with Children's Cancer Foundation, and she's a registered play therapist. And she also likes to do life and death education. So welcome, Yet. And now let's move on to hear what they have to say.
Good afternoon, everyone, and thank you for joining us. I'm Dr. Vancy Kwok, consultant anesthetist at Hong Kong Children's Hospital, and I'm joined today by two colleagues who have shaped how we think about the procedural anxiety. Ms. Yet Tam, Senior Child Life Specialist at the Children's Cancer Foundation, Hong Kong, and Dr. Connie Poon, Clinical Psychologist, also at Hong Kong Children's Hospital. Over the next 20 minutes, we wish to walk you through a case that changed how our team approaches procedural anxiety. We understand that anxiety in kids isn't rare. We're talking 41 to 75% of prevalence, and needle-related fear specifically hits 20 to 50% of children. Anxious kids have dramatically lower sedation success rate by 4 times, with a 10-fold jump in emergence delirium. But this isn't just a number problem. 2 years ago, right here in Hong Kong, a 5-year-old girl came into A&E for suturing at the back of her head. No sedation. She was terrified, so she struggled, but she was held down, and then she stopped moving. That's the ceiling of what this can cost. Not just a failed procedure, not just a bad memory, hypoxic damage, and in this case, death. Anxiety at its worst predicts tragedy. Let me introduce you to a patient I'll call Tina. At the age of 3, she was diagnosed with a brain tumor. Her surgery, chemo, and radiotherapy were successful, but she needed MRI brain surveillance with contrast every 6 months. Initially, things went smoothly. While she still had a Hickman catheter, we completed each MRI with IV dexmedetomidine. After the line was removed, we switched to gas induction, followed by IV cannulation, and then sedation with dexmedetomidine and propofol. It was manageable. But by the age of 5, everything changed. She became increasingly distressed by gas induction and was unable to tolerate MRI without sedation. We tried less invasive approaches, including intranasal dexmedetomidine and topical anesthetic, but they weren't enough. We eventually returned to forced gas induction with physical restraint by both parents and staff. 6 months later, her anxiety was even worse. She refused oral sedation, struggled violently during induction, vomited, and briefly desaturated. We had to abort the sedation, and the MRI was cancelled. And here, I'd like to pause for a moment. and bring you to a decision making. Picture yourself as the anesthetist on this case, right after that failed attempt. You are seeing Tina in your clinic. What will be your next plan? Option A, will you reattempt intranasal or oral sedation, maybe with a bigger dose or a different agent? Option B, ask the pediatrician and neurosurgeon to stop booking anything because this obviously isn't working. This is causing too much trauma, too much stress. Or option C, refer Tina to a child life specialist or psychologist. Or D, something else entirely. Do tell us in the chat.
Yes, can people please launch the options in the poll. So we
Yeah.
now have 30 seconds. So please cast your vote and or drop your answer in the chat if you have some other kind of suggestion. And I'm genuinely curious what this room would do. I believe there is no single textbook answer here, but that's exactly the point. So how did the voting go? Because I cannot see this.
Yeah, so we still have only half of them responded, and I would want to go in for a couple of seconds more to see if more are giving in their thoughts. In the meantime, I would just want to say that the Q&A for this section of the webinar would be taken after this talk session. So I would want everyone to put in their questions in the Q&A box for this section. May I have your permission to stop the poll and look at the results, Fancy?
Yes, please.
Okay.
Wow.
Yeah.
Okay. So there are a lot of A's that we'll try to do something. They do reattempt the intranasal or oral sedation again. But another half of us actually would go for C. And actually that's actually the call I made. I referred Tina to the child life specialist, and that's Miss Yat Tam. And I'll let her pick up the story from here because what happened next in that referral is really where things started to turn around. So thank you, Yat. Can you please continue?
Yeah, and I'm going to ask everyone to close the poll box so that
Good
they're
afternoon,
able to see the
everyone,
video.
and thank you for joining us. I'm Dr. Fancy Kwok, consultant anesthetist at
I
Hong
believe
Kong
it's the
Children's Hospital.
next
And I'm joined today
video.
by two colleagues who have shaped how we think about.
Thank you for the referral from Nancy to get me involved in this case. Let me briefly introduce Child Life Services, which under the American Academy of Pediatric Policy statement, Child Life Services should be part of an integrated, patient and family-centered model that provides psychosocial care in healthcare settings. When I meet with Tina, I assess her personality, past medical experiences, and developmental stage to provide an individualized approach. For Tina, repeated sedation experiences have been highly stressful and traumatizing. I provide trauma-informed care, that's ARC framework. A for attachment, build bonding between her and caregiver. R for regulation of her physical and emotional stress responses. And C for competence, to build a positive self-identity and master developmental milestones. It's important to build rapport, follow her lead, and respect her pacing before intervention. Given that she is a sensory sensitive girl, I use a pay-based approach, incorporating sensory pay and medical pay. When I add her medical experiences, demystify medical equipment, and reduce anxiety. Besides providing preparation and procedure support, as I'm also a registered paid therapist, I provide monthly community-based paid therapy sessions for facilitating her expression. I work with the entire medical team with the ultimate goal of empowering Tina and strengthening her coping skills and confidence. For my assessment, what went wrong for Tina? For healthcare variables, her treatment coincided with the pandemic era, which restricted childline inpatient services and fostered temporary parental separations. And repeated sedation attempts and failed MRI experiences increased her stress. For family variables, inconsistent parenting and lack of parental awareness of Tina's insecurity also increased her anxiety. For child variables, as her emotions stuck in her onset age of 3, lots of magical thinking, such as believing in falling asleep would cause her parents to disappear. She also a sensory sensitive child, easier to feel insecure with unfamiliar environments and new faces, further reduced her ability to cope.
Yet, for working out the causes and hierarchy of Tina's anxiety, as pediatric anesthetists, one of our biggest roles is managing procedural anxiety in children. We know that communication is absolutely important. We know words we choose can either reduce anxiety or unintentionally make it worse. Communication is for sure not only just good bedside manner, but a clinical intervention, an important core clinical skills. However, it is rarely taught or practiced with the same rigor as our other core skills like airway management or regional anesthesia. Carlisle and colleagues observed 12 senior pediatric anesthetists across 83 inductions in an Australian tertiary centre. They found inadvertent negative suggestions in 17% of the inductions. That means 1 in every 6 cases. Fortunately, this is modifiable. This is something we can change. What should we actually be teaching? It's much more than choosing the right words. We need a broad repertoire of verbal and nonverbal communication skills, and the flexibility to adapt them to each individual child. Mann and Kennedy describe 4 core principles. 1. Be child-centered, by speaking to the child first and giving them appropriate control. 2. Be adaptable. Tailor your approach to the child's age and anxiety. Show warmth and empathy to build trust, and project calm confidence through both your words and body language. These aren't soft skills, they are core clinical skills. And like any clinical skill, they are not learned through lectures alone. They require observation, deliberate practice, and feedbacks from experienced clinicians. Once we have those core principles, we can start building a practical toolbox. That toolbox includes both verbal and nonverbal techniques that we can deliberately use during induction. Frameworks like LAOS, that means listening, accepting, utilizing, reframing, and suggestion. Another useful framework is GREAT, greeting, report, establishing concern, addressing it, and providing closure. This can be a useful approach because it's structured rather than relying on instinct. Many of these techniques will look quite familiar because they are rooted in clinical hypnosis. The language we choose, using positive suggestions, avoiding inadvertent negative suggestions, focusing their attention, storytelling, voice modulation, and also our body language and positioning, all influence how a child experiences an induction. These aren't tricks, they are learnable clinical skills. And with that in mind, I'd like to hand over to our clinical psychologist, Dr. Connie Poon, who will introduce the principles of clinical hypnosis and how these techniques can be applied to reduce procedural anxiety in children.
I want to pick up on what's happening inside the child's mind, because that's really where the experience of a procedure is decided. 2 ideas frame this. First, pain and anxiety feed each other in a spiral. So with acute procedural distress, we almost always have to address the anxiety, not just the sensation. Second, as Leora Kuttner, a psychologist known for her work in pediatric hypnosis, puts it, the strain of the pain lies mainly in the brain. What a child feels is not a simple readout of tissue signals. It's shaped by context, meaning, and expectation. For Tina, the mask had become a learned threat cue. Her fear pulled her into a spontaneous trance, but a negative one. Her attention narrowed and absorbed into the threat, and it was physiologically very real. So our job wasn't to force her past that fear. It was to help her become, in the child-friendly phrase we use, the boss of her own brain and body. Let me be clear about what clinical hypnosis means, because it's often misunderstood. The formal definition from the American Psychological Association is a state of consciousness involving focused attention and reduced peripheral awareness with an enhanced capacity to respond to suggestion. In plainer terms, it's absorbed, focused attention on purpose. It's not mind control, it's not sleep, and it has nothing to do with being weak-minded. The child is in charge the whole time. In fact, we never had to control in the first place. And children are naturally hypnotic responders, with peak responsiveness right around 8 to 12. So we are not doing something to the child. We are coaches and guides who use language as treatment, helping the child use skills she already has. In this field, we call it skills, not pills. So, how does this work in practice? It starts with language. We use permissive, invitational language rather than commands. We say when instead of if, because if is a challenge, but when is a permission. We say you may when you're ready, not I want you to. We say do rather than try, because try quietly assumes it might not work. And we add a because, since the child follows a suggestion more easily when there is a reason attached. The same principle runs through how we reframe. Small shifts matter. Don't worry becomes we are here to help you. This will sting becomes you'll feel something, and you may be surprised how little it bothers you. And if you hold still becomes when you're ready. None of this is dishonest. We're just directing attention towards what helps rather than seeding the very fear we are trying to avoid. And then we finish by seeding curiosity and positive expectancy. I wonder how quickly you will notice it feels different. That one line does a lot of work because it turns the child's attention into an experiment rather than a threat. That's the language. Next, the technique we build on top of it. So how does the magic glove actually work? This comes from Leora Kuttner's work, and the technique itself is simple. You have the child pull on an invisible glove, stroke from fingertip to wrist, and define the edge clearly at the wrist so the glove has a boundary. Then compare the gloved hand to the other one so the child notices the change for herself. A few craft points then make it or break it. First, never say no pain. Instead, say something like, you'll notice without being bothered. We are not denying sensation. We are changing the child's relationship to it. Second, this is an adjuvant, not an alternative. Keep the local anesthetic, the EMLA, on board. The glove works alongside it, not instead of it. Third, always reverse the glove at the end and confirm normal sensation has come back. We put it on and we take it off. So, why does all this matter? Why spend time on language and an invisible glove when we are under time pressure? Because the payoff is real. First, for the child in front of us, these techniques lower procedural pain and distress, and just as importantly, they give the child a sense of control instead of helplessness. And that's often the difference between an aborted, frightening induction, and one that actually goes ahead. Second, and I want to speak directly to the practical worry here, a common concern is that this prep work is time-consuming. It isn't. These are non-pharmacological communication skills that fold into what we already do. They have no side effects, and something like the magic glove takes only about 2 minutes. And what we get back is a smoother induction and far less time lost to a child who is fighting or being restrained. So, this often saves time rather than costing it. Third, the longer view, which is easy to dismiss under time pressure. One calm experience shapes the next one. A child who gets through a procedure feeling capable rather than traumatized carries less anticipatory anxiety into the next admission and will reduce the risk of entrenched needlephobia down the road. In effect, we are protecting that child's trust in medical care for years to come. So this is a small investment of skill and language that pays off for the child and for the whole team looking after that child. Rather than just describe the magic glove, let me show you. This is Dr. Vancy Kwok using it with an older adolescent patient. You may wish to notice 3 things in the clip. The patient's focus shifting onto the glove, her body language settling, and the fact that she stays in control the whole time. She's an active participant, not someone having something done to her. The take-home is simple. The right words and a bit of imagination change not just whether a procedure succeeds on the day, but what the child carries away from it.
Tracy，咁我哋咧嚟緊，我哋話要打豆喎，係咪？你好難打嘅。咁我哋而家頭先揾超聲波睇咗呢個位，可能得啦。咁我哋就幫你戴個 magic glove 魔術手套，跟住幫你冇咁痛，好冇 ？OK，咁你睇，咁就你之前都試過 magic glove 㗎，係咪啊？好啦，我哋就試一次。咁我哋帶到上嚟呢度。咁呢個似乎你今日要戴 Elsa 咁長先得喎。OK，你又話中意啲咩顏色㗎？你個 glove？淺藍。淺藍色 Elsa 手套咁長嘅絲質 ，OK， 咁我哋戴上去咯喎，好唔好？咁你就由呢度咁樣戴上去先嘅，一路戴到呢度咁，好唔好？咁呢個手套咧，上次都試過啦，一路戴一陣佢會俾個保護你。而你覺得咧，嗱你個人咧就仲係好清醒係咪？我冇啦，我你銀行密碼係咪？冇問你嗰啲冇查你家宅咁啊！但係咧，佢咧就你咧，你仲覺得嗰個神奇力量就開始發揮緊作用啦。因為佢會保護你，令到你咧嗰個外界嘅刺激冇咁刺激啦，啲痛冇咁痛啦，甚至唔痛啦。咁我喺度戴上去先。平日戴手背嘅，你又真係要戴到上手臂啦。唔怕，我次都。可唔可以幫我揾一個尖嘅鉛筆？有啦，鉛筆已經準備好啦，佢哋好啊。咁我哋再放多少少先，呢度咁樣推上。咁我哋咧要好貼服嘅個手套係咪 ？Make sure 佢個保護咧係可以全方位360咁樣保護住你 ，OK？ 舒唔舒服㗎？大家都可以係咪？你覺得夠透未？我哋試一試好冇？嗱，嗰隻手冇戴手套嘅係咪？你可唔可以話俾我知呢度啦？手臂咧都係。呢個咧就係10/10嘅感覺啦，即係 full 嘅感覺啦。呢邊咧幾多分啊？2分？2分啊！哇，咁犀利嘅！咁你覺得我 ready 唔 ready 可以幫你擺嗰個耳朵？因為 Charity 打完啦喎，你覺得今次戴咗 Magic Glove 嘅感覺點啊
I like it 啊。
I like it 啊？點解啊
Very good 啊。
Charity， 咁我哋咧嚟緊，我哋話要打豆喎，係咪？你好難打嘅。咁我哋而家頭先揾超聲波睇咗呢個位，可能得啦。咁我哋就幫你戴個 Magic Glove 魔術手套，跟住幫你冇咁痛。
I think that's the end of imagination, and she chooses to come along. That's why it works, because she stays the boss of her own brain and body. The fear and the fighting drop away, and you get the calm, cooperative child you saw in the clip.
Thank you to Wency and Connie for sharing the concept of letting the child be the boss of their brain, while parents can act as a supportive partner. Although inconsistent parenting happened, I assessed that mother is a good person to learn this collaborative role in the CARE campaign. The included photo demonstrates how I guided the mother to use a comfort position, back to tummy sitting position, also with mother's one voice, enhanced Tina's sense of security and kept her calm during sedation. For daily life, I coached mother on active listening skills and praising small improvements to help Tina feel respected and confident. I also encourage offering realistic choices using simple language, such as what to bring to the hospital, preferred which comfort position, and how's the sensation about the procedure. Finally, the mother can use a soft tone to validate Tina's emotion by saying it's okay to feel scared or nervous. I'm right here with you.
It's so true that it takes a village to manage a child's procedural anxiety. Now look at the team. Notice where the patient sits. She's one of the team. She's right in the center. She's not at the bottom of the hierarchy. Yes, Tina is an active participant with her own goal setting, not just the subject of our plan. And around her, we have the pediatric anesthetist leading the sedation plan, cross-team safety, and a lot of inter-team communications. The child life handles the preparation and coping rehearsals with the children and handles a lot of parent education and communication. The psychologist, she helps with the phobia formulation, exposure strategies, and hypnosis and family coping. And the parent, they're not bystander, they're an ally of the team. They are also coached into the plan. 6 roles, 1 voice, and a child helping write it herself.
I agreed that Wendy's saying 6 roles work as a cohesive team with 1 voice. The benefits of using 1 voice for children, parents, and health professionals showed on the left side. Let's watch the video demonstration. In the later half, you will see the mother providing a comfort position for her child. Simultaneously, the child specialist coaches the child's breathing and manages distractions, allowing the nurse to insert the IV in a safe and calm environment.
Yeah, come see me. She's like, no, no, daddy.
Do this quick. We're gonna do this quick, quick, honey. Oh, just stand up right where you're at. Hey, catch the bubble. Oh, don't worry, don't worry. I can do it. I always did it the first time. Don't worry. Catch the bubble. Woo! Catch those bubbles.
Where is Daddy? Oh, he'll be back soon. Daddy will be back soon. He will. Oh, I'm so sorry.
All right. Doing the washing, you're getting ready. Okay, now what's the important thing to remember? Get your hand out here and keep it away from the IV. She'll let you know. 1, 2, 3. She'll count for you, okay? Okay, squeeze the bottle. Okay, now, Kristen, take a deep breath and blow it out for me. Good job. Another one. In. Blow it out. Good job. The needle's coming out, but we still have to hold still, okay? Just going to try the drink. You doing okay? Okay, deep breath. Good job. You're doing such a great job holding still. Should we do the iPad now that part's over while she's doing the rest of her work? She's going to tape it up for you? Yeah? What do you want to do on here, buddy? I can't remember what game it is. I know you like to do the motorcycle, the spider. Where's the spider? Like, can you find it? I don't know which one you're talking. The ants? No. What spider are you talking about? Is it the ant smasher one? Oh, yeah.
So finally, how did we help Tina? We started by mapping Tina's specific fears with her and her mother, and just as importantly, identify what she trusted. And from there, the child life specialist and I built a shared plan with small achievable goals with Tina. Our first objective was simply to create a successful sedation experience. We removed unnecessary stress by admitting her to the ward, so this eliminates the time pressure. And we introduced needle and coping strategies such as AMLR, comfort positioning, and provide parent coaching. Sedation was successfully completed in the ward. And once that trust was there, we expanded gradually. The ward, then just outside the MRI room, and then inside it, with me coordinating the timing across the radiology, the ward, and the referring team, so nobody and nothing felt rushed. Anxiety was reduced systematically through multidisciplinary collaboration, greater exposure, and repeated success. And this is how Tina's confidence is rebuilt in graded, small, celebrated steps.
Regarding psychosocial improvements, Tina initially felt confused and overwhelmed, but she now shows a much better understanding of her diagnosis and the necessity of periodic MRI scans. From a sensory perspective, she strongly disliked using amner cream at first, but she can now accept and tolerate it. Emotionally, she used to feel fearful and nervous throughout the entire process, but she now can more calm and smile sometimes, even during sedation induction. Finally, in terms of confidence and coping, Tina avoided discussing MRIs or any medical issues. Now, she willingly participates in medical play, reenacts her experiences, expresses her feelings more freely, and even praises herself for being brave.
So how do we help a child move from procedural anxiety to confidence? We understand Tina's fears. We remove unnecessary time pressure, gradually moving her from sedation from the ward into the MRI suite. Meanwhile, building her coping skills, introduce her to with the skills of hypnosis, and making sure that the whole team, including her parents, use consistent supportive communication. Most importantly, Tina set the pace. Every session had a small goal, and every success, even a partial one, was celebrated. Tina's story also reminds us of something important. It's much easier to prevent procedural trauma than to undo it. By the time she came to us, we were trying to reverse years of fear, and that took far more time and effort than prevention ever would have. So I'd like to leave you with 3 take-home messages. First, procedural anxiety is a clinical problem, not just an emotional one. Second, communication is one of our most powerful therapeutic tools, and we should train it with the same intention as any other clinical skills. And finally, confidence is built one positive experience at a time, with the support of a multidisciplinary team working towards the same goal. Thank you very much for your kind attention, and we will be happy to take any questions.
Thank you, Vancy and Tim. It's amazing and it's just very magical when you use therapeutic communication and when you know how to use suggestion and hypnosis. So I think there are a couple of questions on the Q&A. The first one is on the magic glove. How old would that be? How would the child need to be when you can use this technique on the children?
Maybe I answer for Connie first because I see that Connie is typing an answer for another question. Well, for a magic glove, usually it works better if the patient is being able to understand what you're talking about. some said it's around 8 to 12, but according to my experience, it actually can work for even age 4 and or age 3 sometimes. We can modify it from magic glove to magic sock even, or a magic stocking, everything. It works. It works for children. And in fact, I've tried it in adults as well, as I was demonstrating to a lot of physicians or anesthetists, and I show them demonstrated magic glove on them. Most of them, I'm not saying all, but most of them likely 90% experience a major reduction in the sensation. So it does work. The imagination works in adults as well.
And so there is another question on referral to child life therapy. So how far ahead, like how long does it take for the child life to work with Tina, and how far in advance do we refer to child life therapies for patient we anticipate issue or anxiety?
I worked with Tina, I think around nearly 2 years. So you can know that we need to step by step, and also we need to let her know her improvement step by step. So if you have the child life specialist in hospital, I recommend that you can, if you find the children, maybe they have special needs, or they have more anxiety when come to see the doctor for some appointment, I think it's good that you can earlier to refer to the child life specialist, because some children like Tina, maybe she need more time to meet with new people, and she need more time for preparation, and then the child life specialist can stay with her to do the procedure support.
Right. Thank you. So, and then there is also another question on magic glove, because I think everyone is very amazed about the magic of the glove. So this attendees ask, what if it doesn't work? What can you do, or do you come back for another one, or continue with a different technique?
Connie, do you want to go first?
Hello. Should I answer live or should I answer?
Yes, you can answer live.
Okay, that's a very interesting question. I can't say for sure that magic glove can work. It is a useful techniques, and it worked on a number of kids, although some are quite skeptical about this and may not buy it. In any case, hypnosis is the kind of technique that help focus children's attention. And it helps us give suggestion of confidence, good expectations, and success more successfully. Of course, there are other ways for us to deliver a message that things will work okay and you can cope with it. Magic glove is only one avenue, but that's not the only avenue. So, of course, there are other ways that we can try to capture the child's attention and focus attention, that we can work things around.
Right. Yeah. I think
can I just take a couple of the ones that are there? Yeah. I mean, I think this was running through my mind as well, that do you involve the pediatric psychologists for all the cases? Would they be required for all? No. Yeah.
No, actually, no. Actually, it's quite unusual for us that we need Connie, but for Tina, she is one of those very tricky ones that we need a very special support, and we see how the whole team come together. In fact, but I think the tricks or the communication that are suggested by Connie, the hypnotic language, or the communication skills we use, or even the hypnosis skills, can also be applied by the anesthetist. And in fact, I learned about these cases, these techniques after recommended by Connie. I attended a course held by the American Pediatric Hypnosis Society on pediatric hypnosis, and it's specifically held for pediatric anesthetists. And this is how I learned about the pediatric hypnosis, and I find it very, very useful. Yes.
Thank you.
It's only one. It's only one. It's only one of the skills. I say it's only one of the copings and also one of the strategies that we apply on Tina because it's in fact a lot of communication. We need to know why Tina is so scared. We need to know how the parents can be equipped and help Tina. We need to know how to communicate with Tina, and we also need to set small goals or develop strategies along the way. And through the 2 years time, yet keep on communicating with the family and also with Tina to build her skills and also to help her to tackle her anxiety. And when we cannot do it by ourselves, we need to find Connie and her team to help. And this is how the referral usually goes.
Sure, thank you. Just one more question that I feel is pretty connected to this. And at what point would you want to use some medication? Like I think someone has asked about using midazolam, using clonidine, dexmedetomidine. At what point do you want to switch from non-pharmacological methods to pharmacological?
I'd say the non-pharmacological treatment can always work with the pharmacological treatment. And because of non-pharmacological treatment is just day in, day out communication with our patients. So it is like the core. It's like the basic, because you will talk to the kids, you will meet them. This is not just basic bedside manners, but it's actually a clinical skills. We would like to emphasize that non-pharmacological is not an add-on. It is a must. And as for pharmacological, yes, we use that as well. Although our ages might be slightly different, but for Tina, why is it so challenging? Because she refuses all. Intranasal dexmedetomidine does not work on her. She is very, very anxious towards mask and also sevoflurane induction. And she does not tolerate any oral pre-meds as well because she is very sensitive to taste. She's actually quite chubby, if you know. If she can sense a little bit alteration in taste in the apple juice because of with the addition of midazolam, she knows and she stopped drinking it immediately. So it doesn't work as well. And if you told them it is a medication, she will for sure say no. So oral medications, nasal medications, gas, everything doesn't work. And she's also needle phobic. And therefore, it is very challenging for us. And that's why we need to use this special approach.
Thank you so much. I can see many questions being answered already by our panelists. Vivian, would you want to ask?
Just one more question maybe. I can see the importance of therapeutic communication in our work, how we talk to our patients. However, I can also it's difficult for everyone to learn and learn together because sometimes we work in a team. Sometimes we might know we should not be saying, this will cause you pain. But then everyone around you will say the same thing. I just guess the training and teaching is important, but it's not just to the anesthesiologist, but to everyone, like the nursing team and the supporting team. Because otherwise it will be like in your video, or first video of Tina when there is a group of people saying and trying to help and distract the child by causing more anxiety, I think.
Yes,
thank you. Yeah, I just wanted to ask one more question to Vancy, and that's if you're using Magic Glove repeatedly for repeated admissions that the patient comes for, does it turn out to be more effective or less effective?
Actually, after once or twice, the kid can put it on by themselves. They do not need me. Yes, they learn the trick. And then sometimes they would tell me they have extended glove to here onto the deltoids for the vaccinations. And then because they also learned, and not just the magic glove, but also some other hypnotic techniques as well. For example, some imagination, like my favorite place, or some will go for magnet fingers. I'm sorry that we have a very short time today, so we cannot go over the details for hypnosis. But in fact, the kids eventually do this hypnosis themselves. All hypnosis basically becomes self-hypnosis. We are only facilitating everything that happens. Connie, do you have anything to supplement?
What a wonderful answer, Vancy. Ultimately, all hypnosis will be self-hypnosis. So we can't do things to kids, but kids can help themselves. We are here to help the kids help themselves. So once they master it, they can repeat it themselves.
Sorry, one more question before Connie leaves, and that's how do you differentiate between distraction techniques? I think distraction techniques are something that we use more frequently on this side of Asia. And now I see hypnosis being used, even moving on to self-hypnosis. So which one do you think is good? And is it okay to use distraction? Is it equally effective?
Actually, we can use both, but I myself prefer hypnosis because it's attention-focused attention with intention. So hypnosis is actually like when you're watching a movie, you're right into there. You got the message, you got immersed in it. We often go through problems rather than go around problems. When we go through problems, when we go through difficulties, we emerge stronger. So my personal preference is hypnosis rather than distraction, but I can understand that distraction can also work. Yeah.
Emerge stronger. I really liked it. Thank you.
Thank you.
Thank you, everyone. So I think there are a couple more questions. We can answer it on the Q&A box. We will introduce our next speaker. Thank you, Yeti, Connie, and Vancy. Our next speaker is Ms. Q Hong. She is from the Chongqing Children's Medical Center. She's Associate Chief Nurse and Postgraduate Supervisor at the Chongqing Children's Hospital. And then she has a lot of important position in committees and association. She's the Vice Chairman of the Operating Room Nursing Committee of Chongqing Nursing Association, and she has many awards, including the Regional Excellence Award for Chinese Hospital Management Advanced Individual in Nursing Service of Yongzhong District, Chongqing, and Most Beautiful Head Nurse of Chongqing. Welcome, Qiu Hong.
Thank you. Hello, dear colleagues. It's a great honor to share our experience with pediatric experts here. I'm from the Department of Anesthesiology at the Children's Hospital of Chongqing Medical University. Today, I will share with you how we built a high-quality and high-safety pediatric sedation center. This is not only a demonstration of technology, but also our promise to every young patient. First, please allow me to introduce our home base, the Children's Hospital of Chongqing Medical University. We are an aircraft carrier in the field of pediatrics in western of China, with 2 campuses and over 2,500 beds, and our comprehensive strength is firmly in the national first tier. The annual sedation value of our anesthesiology department is as high as over 80,000 cases. This is huge value, is both pressure and powerful driving force for our continuous pursuit of excellence. Today's presentation will take you behind the scenes of our sedation center to explore 3 core secrets. First, how we built an indestructible safety net, a standardized nursing management system. Second, how we forge a sharp scalpel, a systematic specialized nursing training program. Finally, I will show you the fruits we have harvested and our beautiful vision for the future. Our development journey is like an exciting relay race. From the establishment of the first outpatient sedation center in 2060 to the opening of the inpatient sedation center in 2017, and finally to the establishment of a more advanced sedation center at the new Liangjiang campus in 2020. Every step embodies our persistent pursuit of quality and safety. Our core management principle is centralized and homogenized management. This means that regardless of which campus a child is in, we guarantee high-quality service with the same recipe and the same taste. Yeah, it's like a chain brand ensuring that every store's products meet the highest standards, thus ensure uniform quantity, resource sharing, and controllable risk. Safe sedation is inseparable from sophisticated weapons and equipment. We strictly follow the internationally accepted SOAPME principle, equipping each sedation unit with a luxury package, from suction, oxygen, and airway management to emergency medications, vital sign monitoring, and defibrillators. We have achieved having everything needed and being prepared for every eventuality. This standardized equipment is our confidence and reassurance in dealing with various emergencies. If the sedation process is a performance, then our standardized procedure is the precious script. We divide it into trilogy: pre-sedation, inter-sedation, and post-sedation. From rigorous assessment and standardized fasting to standardized monitoring and individualized medication, and then to close observing and ensuring safe discharge. This is a complete closed loop, ensuring every step is accurate and error-free. We also hope families can learn about sedation procedure in advance. So we hand drew illustrations to produce science popularization and in education videos, aiming to get families on the same page as us. Supporting all of this, our powerful intelligent sedation system. It acts like an invisible guardian throughout every step of the children's visit, from arrival, medication, examination to discharge. The system collects and monitors data. More importantly, it proactively ensures safety. Through wearable devices, we can locate and rescue children with special conditions within 1 minute. The system also coordinates multiple departments to ensure timely examinations and issues warning for children who do not return on time. This system is our secret weapon for ensuring safety. And these are the 5 key stages of sedation for our patients. Unique data of each child patient will be generated in the system at every stage, including vital signs, sedation history, medical history, and even whether the family is at high risk of feeling complaints, which reminds our nurses to take preventive measures in advance. That's very important. Okay, this is a detailed procession flow for each node. So here is the demonstration. We will ultimately develop an in-house sedation system. It provides full process monitoring to track the completion status of every single step from the moment a child enters the sedation center until they discharge, acting like guiding lights. The system's safety escorts sedation patient out of the hospital. We never shy away from risk. Instead, we choose to face the management to manage them. The sedation center's distance from operating rooms, yeah, surely, limited space and difficult observation are all challenges we must overcome. Our strategy is arm the team with the strongest training, response to emergencies with the most comprehensive protocols, and seek support with the fast linkage mechanism. We believe that anticipating risks is the key to responding calmly. In our sedation team, anesthesiology nurses are undoubtedly the leading actors. They are the executors of protocols, the guardians of life, and a warm bridge connect with doctors, children, and their families. To make the team more combat effective, we have established the core role of a specialized team leader. They are like the champions of the team, leading the team on the course of high-quality service. Our training goal is very clear: to build 3 capability nurses able to assess, able to monitor, and able to respond to emergencies. It's like training an all-round special forces soldier, and all of this is led by our experienced specialized team leaders. They are not only coaches, but also examiners, ensuring that every nurse on our team can become an expert in their own right. Our training system is not a one-size-fits-all approach, but teaches students in accordance with their aptitude. For new nurses, we have 3 months recruit training camp, providing hands-on membership to ensure they lay a solid foundation. For in-service nurses, we provide continuous advanced education, encouraging them to become subspecialty backbones. We believe that only through continuous learning can we maintain the team's vitality and competitiveness. Newly recruited nurses will receive training within the curriculum system from standardized training anesthesiology residents. They will also attend weekly nurse award rounds with lectures and submit weekly learning experience records. In addition, they will take online courses covering cutting-edge professional knowledge. It is necessary to first understand the responsibility of each position, and the workflow of the sedation center. This is the operation process, and this is the emergency procedures, part of the emergency procedures. And the new nurse must be aware of management of all links. The head nurse ensures the scheduling of the nurses' cleaning division and of the labor and reasonable scheduling. Practicing nurse will pursue further profession development by attending domestic and international conferences and further training programs. Meanwhile, they will deliver lectures to staff in collaboration departments and set up communication groups to answer questions online. Participate in quality control monitoring, reporting, and recertification at the same time. Here is the pictures. High fidelity simulation training is our secret weapon. Here, we can simulate various thrilling scenarios, from common respiratory depression to real cardiac arrest. It's like a pilot's simulator, allowing our nurses to repeatedly practice responding to various emergencies in an absolutely safe environment, significantly improving the team's practical ability. Our training method follows the golden rules of the serial simulation practice Trinity. In this process, specialized team leaders are involved throughout. They are not only the grandmasters who teach the mental method, but also the guides who lead new recruits to roam the rivers and lakes. What is the secret to maintaining professional vitality? The answer is continuous learning and effective communication. Anesthesiologists are frequently invited to deliver lectures. We require the main nurses to hold BLS and PALS certificates and undergo regular retreating. Meanwhile, we have established a weekly train leader meeting system. This is not just a work report meeting, but a meeting of wise minds, where everyone shares experience, solve problems, and progress together. After talking so much, so how effective is it? Data is the best proof. Our sedation success rate exceeds over 95%. The severe completion rate is below 0.1%. We complete over 200 sedation cases daily, and the parental satisfaction is as high as over 98%. Behind these numbers is the hard work of every team member, and it's also the best reflection of the effectiveness of our system. Looking to the future, our steps never stop. We will embrace information to make process smarter. We will explore new technologies such as target-controlled infusion to make sedation more precious and safer. And we hope to strengthen cooperation with all colleagues here to share experience and jointly draw a ground blueprint for the course of the pediatric sedation. That concludes my presentation. Pediatric sedation is a challenging yet meaningful task. We are well aware that there is still much for us to learn and improve. Thank you all very much for your patient listening. So now I'm very happy to answer everyone's question and look forward to more in-depth exchanges with you. Thank you.
Thank you. Thank you so much, Hong, for sharing the strategic planning, workflow management, as well as training that underlies running this nurse-led service. Truly inspiring. Thank you so much. For our audience, you could leave the questions in the Q&A box for her, and we will move ahead with our next speaker. And our next speaker is Billion Lee. She is Professor and Chief Physician of Anesthesiology at the Guangzhou Women and Children's Medical Center. Her research integrates technology into pediatric anesthesia and sedation management strategies. And today she's going to talk to us about absorption pharmacokinetics and dose optimization of intranasal dexmedetomidine in preschool children. So welcome, Billion Lee, and over to you.
Good afternoon, everyone. I would like to start by thanking Vivian Yuan and the organizing committee for the kind invitation to speak today, and thank our moderator for the introduction. It is a real privilege to be here with you. Here, we are using intranasal dexmedetomidine on a weekly basis, and we all have our preferred doses. So today, I will share what we found and how it changes the way we should be thinking about dosing. Intranasal dexmedetomidine has become popular for pediatric procedural sedation, MRI, CT, preoperative sedation, no needle, no IV, minimal respiratory depression. It sounds perfect, but here is the problem. If you look at the literature, the doses people use vary fourfold from 1 to 4 micrograms per kilogram. Why? Because we simply do not have enough basic pharmacokinetic data to tell us what the right dose actually is. The bioavailability estimates range from 41% in awake adults to 84% in anesthetized children. That is nearly a twofold gap. Clinically, this means that if you give the same dose to two children, one might be perfectly sedated, the other barely touched, and a third might have gotten more drug than they needed. And there's another layer of complexity. Between 3 and 47 months of age, the nasal cavity doubles in volume. The mucosal absorptive surface is changing size while we are trying to dose across it. Yet, no one had systematically studied how this affects drug absorption in this age window. So here we did. This slide also tells a story of what we know and what we do not know. On the left, the good news. Intravenous dexmedetomidine pharmacokinetics are beautifully characterized. We have a universal model published by Morse and colleagues in 2020 that works from neonates to adults. It has been validated across multiple independent datasets. Now, look at the right side. Intranasal absorption in young children. There are 3 critical parameters that determine how much drug reaches the blood after nasal delivery: the absorption half-life, the absorption lag time, and the absolute bioavailability. In children aged 3 to 47 months, not a single one of these had ever been estimated with precision. Without these parameters, you cannot predict the concentration time profile after intranasal dosing. And without that prediction, you cannot derive evidence-based dose recommendations. The fourfold variation we see in practice is the direct result of this knowledge gap. So we designed a study with 3 clear aims. Aim 1. Characterize intranasal absorption in children aged 3 to 47 months. Specifically, nail down the absorption half-life and absolute bioavailability. To do this, we pooled our intranasal data with 5 existing intravenous datasets using the Universal Allometric Maturation Framework. Aim 2. Define the hemodynamic safety profile. We used the fractional Emax model to link dexmedetomidine concentration to mean arterial pressure. The question was simple. How much does blood pressure actually drop? And does it get worse at higher doses? Aim 3. Model-informed dose optimization. We ran Monte Carlo simulations with 1,000 virtual children per dose from 1 to 8 micrograms per kilogram. We evaluated target attainment at 2 sedation thresholds derived from adult pharmacodynamic data: 0.6 micrograms per liter for light sedation and 1 micrograms per liter for moderate to deep sedation. Let me walk you through what we actually did. 30 children aged 3 to 47 months, ASAI or 2, scheduled for interventional radiology. You might ask, why under general anesthesia? That was intentional. Anesthesia guarantees precise dose delivery, standardized positioning, and an uninterrupted blood sampling schedule. Sevoflurane was maintained at 0.6% to 1% end-tidal, with BIS between 40 and 60. Children were randomized within 2 age strata, 3 to 12 months and 13 to 47 months, to receive either 3 or 4 micrograms per kilogram. We used dexmedetomidine at 100 micrograms per milliliter, delivered through a commercial mucosal atomization device split equally between both nostrils with the child supine. Arterial blood was drawn at 5 time points: 18, 30, 40, 5, 60, and 80 minutes after dosing. Plasma concentrations were measured using validated UHPLC MS. We pooled our 30 intranasal subjects with 5 external intravenous datasets. Altogether, 222 subjects and 2,373 observations. This pooling strategy let us estimate absorption parameters while reach intravenous data on drug disposition. Analysis was done in NOMEM using first-order conditional estimation with interaction. Here are the results. Our final cohort, 30 children, 14 in the 3 microgram per kilogram group, 16 in the 4 microgram per kilogram group. Median age was 13 months, ranging from 3 to 47 months. Median weight was 10.2 kilograms. The 2 dose groups were well balanced on age, weight, and procedure duration. The age stratified randomization worked exactly as planned. We collected 130 scheduled plasma samples. The inter-assay coefficient of variation was less than 7.67%. Excellent analytical quality. Alright, here is the number I want you to remember from this talk, 80.5%. The absolute intranasal bioavailability of dexmedetomidine in these anesthetized children is 80.5%. But what really impressed me, the between-subject variability in bioavailability was only 12.7%. That is remarkably low for an absorption parameter. It tells us this route is not just efficient, it is reproducible. The second key number, absorption half-life, 2.2 minutes. This lines up nicely with the 46 minutes that Miller and colleagues reported in children aged 6 to 48 months, and it is much faster than the 120 minutes Tiannan found in anesthetized adults. The explanation is straightforward. Children have thinner nasal epithelium and higher mucosal blood flow. Both accelerate drug transfer across the mucosa. Let me translate this into something clinically useful. If you give 4 micrograms per kilogram intranasally, roughly 3.2 micrograms per kilogram ends up in the systemic circulation. That is a remarkably efficient route. The disposition parameters clearance and central volume are completely consistent with the universal model from Moss and colleagues. The allometric maturation framework holds up beautifully. You might be thinking, wait, Lee and colleagues in 2018 reported bioavailability of only 41% in awake adults. How did you get 80.5%? That is nearly double. 4 factors explain this difference. First and most important, our children were anesthetized and supine. In awake adults, up to half of an intranasal dose is not absorbed where it gets swallowed. The supine position prevents this gravitational loss. Second, we use a mucosal atomization device. It produces a fine mist, droplets in the 30 to 100 micron range, maximizing contact with the nasal epithelium. Drops produce larger volumes that run off and get swallowed. Third, children have smaller nasal cavities, better drug retention at the absorptive surface. Fourth, children have thinner nasal epithelium and higher mucosal blood flow. Both enhance transmucosal permeation. Here is the punchline. Our 80.5% is not an outlier. It matches the 83.8% reported independently by Miller and colleagues in 2018. 2 separate studies, 2 different pediatric cohorts, both finding approximately 80% bioavailability under optimized delivery conditions. That is reproducible science. I know many of you are thinking, what about hypotension? Does intranasal dexmedetomidine drop the blood pressure? Our data say something quite reassuring. We used a fractional Emax model to relate dexmedetomidine concentration to mean arterial pressure. The maximum fractional map reduction Emax was only 7.92%. That is a very shallow ceiling. But here is the really important finding. The C50, the concentration that produces half of the maximum effect, was 0.008 micrograms per liter. The clinical sedation range is roughly 0.3 to 1.5 micrograms per liter. Do the math. The C50 sits approximately 100-fold below the therapeutic window. What does that mean at the bedside? Once you have reached a sedative concentration, the blood pressure effect is already maxed out. You are on the plateau. Increasing the dose further does not produce additional hypotension. The MAP response has hit its ceiling. This is fundamentally different from IV bolus administration, where you can see 15 to 20% drops in blood pressure. In our study, we saw transient mild hypotension in 5 of 30 children. Every single episode resolved spontaneously. No intervention was needed. The median dexmedetomidine concentration at onset was 0.79 micrograms per liter, and concurrent sevoflurane may well have contributed. The take-home is simple. Across the 2 to 5 microgram per kilogram range, we found absolutely no evidence of dose-dependent hypotension. Now we get to the question that really matters clinically. What does each dose actually achieve? We evaluated 2 targets. 0.6 micrograms per liter approximates light sedation. The child still responds to tactile stimulation. 1 micrograms per liter approximates moderate to deep sedation. The child responds only to painful stimuli. Look at the left panel first. Light sedation. The dose-response curve has a clean sigmoidal shape, and the steepest part runs right through 2 to 5 micrograms per kilogram. At 1 microgram per kilogram, less than 1% attainment. Forget it. At 2, 33%. Still not reliable enough for clinical use. At 3 micrograms per kilogram, 83.1% attainment. Median duration 130 minutes. This is your sweet spot for light sedation. At 4, 98.2% attainment, median 177 minutes. Near universal success. At 5, 99.8%. But honestly, when you are already at 98% with 4, the incremental gain is tiny. Now the right panel, moderate to deep sedation. At 3 micrograms per kilogram, only 21%, not enough. At 4, 56.6% attainment, median 50, 2 minutes. This is the threshold dose for reaching moderate to deep sedation. At 5, 80.3% attainment, median 111 minutes. The key takeaway: the dose-response curve is steepest between 2 and 5 micrograms per kilogram. That is our evidence-based effective range. Let me translate this data into clinical recommendations. 2 micrograms per kilogram. A 33% success rate is not acceptable for procedural sedation. 3 micrograms per kilogram is your go-to dose for light sedation. Echocardiography, CT scanning, any short non-painful procedure. Expect 83% success with about 2 hours of sedation. 4 micrograms per kilogram is what you reach for when you need greater than 90% probability of success, a longer procedure like MRI, or if you want a chance at moderate to deep sedation. At this dose, 98% achieve light sedation and 57% reach the moderate to deep threshold. 5 micrograms per kilogram is the maximum I recommend. It gives 80% moderate to deep sedation for a median of nearly 2 hours. Useful when deeper sedation is needed, but you want to avoid placing an IV. However, I would not go above 5. Recovery time is dose-dependent. Plan your monitoring accordingly. Let me address a question I get asked often. If I give 4 micrograms per kilogram to a 5 kilograms child and a 13 kilograms child, will their plasma concentrations be the same? The answer may surprise you now. Here is why. Dexmedetomidine clearance follows allometric scaling to the 0.75 power of body weight, not a linear relationship. And on top of that, clearance maturation is still ongoing in these children. At 4 micrograms per kilogram, the predicted Cmax in a 5 kilograms infant is 2.01 micrograms per liter, while in a 13 kilograms toddler, it is only 0.82 micrograms per liter. As you can see, all 3 weight groups exceed the light sedation threshold good, but only the 10 kilograms child reliably reaches moderate to deep sedation. A 13 kilograms child may need 4 to 5 micrograms per kilogram to achieve the same sedation depth as a lighter child. The clinical point: within this age range, heavier children may need doses at the upper end of our recommended range to achieve the same sedation depth. 6 key messages from this work. 1. We can now dose with precision. Replace empirical dosing with evidence-based selection grounded in robust pharmacokinetics. 2. The safety margin is wider than many people assume. MAP reduction caps at 8%, no dose dependence across 2 to 5 micrograms per kilogram. This should give you confidence. 3. Use a stratified approach. Match your dose to the required sedation depth and procedure duration. 3 for light sedation, 4 for high confidence or moderate to deep, 5 as an upper bound. 4. Remember that weight matters. Heavier children may need proportionally higher doses. Factor this in when you prescribe. 5. Recovery is predictable and dose dependent. 6. We now have a defined upper limit for evidence-based use. Do not exceed 5 micrograms per kilogram without more safety data. 2 to 5 is your therapeutic window. I need to be transparent about what this study does not tell us. Our sampling schedule was sparse, 5 time points per subject. This was sufficient to estimate the core absorption parameters, but it means we could not estimate the absorption lag time precisely. We also needed external IV data to compute absolute bioavailability. That is a limitation. All subjects were under sevoflurane anesthesia. The hemodynamic effects we observe might differ in awake children. Keep this in mind when interpreting our MAP data. We did not directly measure sedation depth. All subjects were anesthetized. The 0.6 and 1 microgram per liter thresholds come from adult pharmacodynamic literature. But even with these limitations, the bioavailability CV was only 12.7%. The Emax was estimated with acceptable precision, and our model was independently validated against our own 2022 anesthesiology paper. These dose recommendations are clinically actionable now. So let me leave you with a big picture. What do these numbers actually mean for your practice? First, we now have clarity on a question that has been open for too long. When you give intranasal dexmedetomidine to a child in this age group, you can expect about 80% of that dose to reach the bloodstream, with an absorption half-life of just under an hour. Second, the hemodynamic safety margin is real. The blood pressure response hits a ceiling at around 8% reduction, and it simply does not get worse as you increase the dose. That plateau effect is biologically interesting, but it is also clinically useful. Third, we now have an evidence-based framework for selecting a dose. If you need light sedation, 3 micrograms per kilogram is your dose. If you need more reliable coverage or a chance at deeper sedation or a longer procedure, move to 4. So in short, we have moved from empirical guessing to data-driven dose selection. And that, I hope, will make your clinical decisions a little easier and your patient's experience a little better. I want to thank my co-authors, especially Yan Ping Wan, who shares first authorship Dr. James Morse and Professor Brian Anderson for their pharmacokinetic modeling expertise, and Vivian for her critical review. Thank you all for joining us online today. I really appreciate you taking the time to be here. I see we have the Q&A function available, so please feel free to type your questions into the chat or the Q&A panel. I will do my best to get through as many as I can in the time we have left. Thank you again for your attention, and I look forward to your questions.
Thank you very much for Hong and Billion for the fantastic talk. It's just 15 and 20 minutes talk, but there were over years or decade of hard work and tremendous effort. So especially for Hong leading a team, going beyond operating theater and leading sedation service. And then Billion has been spending a lot of efforts on the pharmacokinetic of dexmedetomidine. Initially, when we just started using it, we just know it's effective, but we have no science behind. And now we have all the science review and we can do this precisely. So there are some question from the Q&A box. I think repeatedly people do not have atomizer and they ask if you can use the drops to administer dexmedetomidine. I'm not sure if Billion is around or she's still working in operating theater. It's okay. If not, then I can answer the question. If you don't have atomizer, you can do the drops, but I can't tell you exactly whether the bioavailability is 80%, because I think we do not have the answer. I think in the past when we did clinical comparison as well as pharmacokinetic studies comparing atomization and simple drops, we do not see difference clinically and we do not see difference in plasma level. But that was on adult patient. But I think that is also reassuring that if you do not have the atomizer, by all means, just give it with simple drops. But I would recommend that you don't give it in a hurry, but give it drop by drop slowly so that it won't be outside the nostril. That's all. So that is one. And then
sorry to interrupt. Could I have our panelists to put on their videos, please? Billion, Connie, Vancy, please put your videos on. Thank you. Over to you, Vivian.
So, Billion, if you have anything to supplement, please go ahead. And then I have a question for Hong, because I see that with your service, obviously you have a high success rate, efficient, and you do a massive number of sedation in the center regularly. How do you measure the satisfaction rate of the parent? Do you send out survey or how do they let you know they are satisfied with the service?
We always collect the satisfaction of the parents from the other one collect the satisfaction, not with us, because sometimes maybe they think the fake. So they will respond to another corporation or like that, corporation company or like that. Yeah, they can collect the satisfaction of the families. Yeah.
You mean it's electronic?
Yeah.
I see. Thank you. So that's the next level of sedation service. And then I think there are also a lot of questions on dexmedetomidine. One is for nutritionally poor patient. How do you decide on the dose? I guess you have to have extra vigilance for the sick kids or underweight kids or patients that's outlier. So we always have to be more careful. So sometimes we might have to err on the lower dose, and then we have to prepare to titrate in more sedative by other means when it's necessary. So that will be my answer. I don't know if Billion can supplement or answer here.
I think Vancy is marked it as live. Vancy, do you want to add in there?
No, I'm marking for my boss.
And then, so nebulized desmedetomidine is a suggestion. So I think if anyone want to research and try that out, we would love to hear your experience. But it just need more apparatus because there is some fear of nebulization during the COVID period, but I guess maybe not quite now. And then whether you use IV on top of nasal desmedetomidine sedation really depends on what you do, like what you use the sedation for. Like if you're doing a light sedation for CT or pre-medication for before anesthesia induction, or you are using it solely for hearing test, that's all different. So it really depends on the context, how you use it. Now we have more information understanding the pharmacodynamic that may help you to gauge what dose you use and how do you do the whole procedure, sometimes not just one drug, but sometimes if you want to speed up or a simple procedure, you may be okay with just the one drug. Yeah. And I guess in Hong Center, they combine desmedetomidine a lot with midazolam for a lot of procedure with high success rate too. So, but it's all protocolized, so it's good that you have the experience and you know what to do when and to do to who. Any other suggestion regarding desmedetomidine or nursing role in sedation service?
Many questions still pending, Vivian. I can see a lot of enthusiasm from the attendees. I think we spoke about hypotension, but would Billion tell us if she has experienced bradycardia and what doses would be safe? Is Billion around?
I think she's actually still in OR. That's why she's muted. I'm sorry, she's too busy. I think so we're talking about bradycardia is usually with desmedetomidine given nasally with the recommended dose. We don't see that bradycardia that need to be treated in most kids. I mean, if it's not the outlier who's very sick or who has brainstem compression, raised ICP, then it's very safe in terms of hemodynamic and respiratory wise. So
and then is there any ceiling dose that you would want to use?
Yeah, my ceiling dose would be 2 ml per kilo for the very big kids. It's like if there is an obese kid, so like I have 100 kilo, I won't go 500 or 400. Because just now the pharmacokinetic data is up to 47 months, up to 4 years old. So for bigger kid is different. So I would limit to 150 or 200 if you say this is an adult. So if I'm giving it to an adult size, I may use around 2 to 3 ml per kilo. But this is just intuition. We have no pharmacokinetic of intranasal desmedetomidine in adult with obesity. We do have that on the adult, healthy adult using 2 ml per kilo. And then there is a question on whether you experience gagging or coughing. Not really, but sometimes they whinge and cry a bit after after the nasal drop or nasal spray. Yeah. I think we answer most of the question, right?
Yeah. I think there's one question on lozenges. I have no experience with dexmedetomidine lozenges.
Is that right? Is it available? I would love to know.
No. No, not in India.
Actually, I think there are special administration formula for dogs or something for their agitation.
But at this point, I just wanted to emphasize that the absorption kinetics are very different when it goes oral as compared to intranasal. So again, we probably need to study it the way intranasal has been studied for using oral form of dexmedetomidine.
Orally is very poorly absorbed. Yeah.
Yes. Yeah.
Okay.
Okay.
So yeah, I think we do have a very fruitful webinar covering all aspects about sedation service. Sedation service is about teamwork. I mean, without nursing, we cannot be successful. It's about research, communication, and how we interact with our children. So thank you all for attending, and thank you all the faculties and speaker, and thank you, Viva, for being with us. So we will have our last bit of housekeeping before we close. Thank you.
Okay. Thank you so much, Vivian. Thank you all our panelists, speakers. Thank you, attendees. I just wanted to remind attendees that they would receive their certificate of attendance, provided they'd filled in the post-webinar survey. And not just for the certificate, I wanted to say that the survey responses really help us understand what you found good and what was not so good in the webinar so that we get an opportunity to improve for the next time. Also, I wanted to tell everyone that our next webinar is on 23rd of August, and this is by the Pediatric Pain Special Interest Group, and it's going to be fireside chat, navigating complex pediatric pain cases, pearls, pitfalls, and practical solutions. So stay tuned with us. You could also follow us on our social media websites, the ASPA website, the Facebook, YouTube channel where this video recorded is going to be uploaded. Also Instagram, we have a channel that you could follow. And just to say that ASPA is a non-profit organization. Our mission is to foster the highest standard of pediatric anesthesia care in Asia. So we seek your help for donations and help us in our cause. We have a QR code out here that you can scan for the donation. You could also keep track of what activities ASPA is doing through our ASPA newsletter. The last one was in May 2026. The 4th issue was released and it's available on the ASPA website. The next one is expected in August. We've also started ASPA podcasts where we've been inviting senior leadership and anesthesiologists who've shaped the pediatric anesthesia in Asia. So please log on to the Spotify and Apple podcast channels of ASPA to listen to these. And last but not the least, a warm welcome to all of you for the next ASPA conference, which is being hosted by the Vellore team, Christian Medical College Vellore. Dates are September 10th to 12th, and we have a good range of workshops and keynote speakers and good academics for this session. So please join us for ASPA. With this, time to say goodbye. It was nice to see so many of you logged in. Those who are interested in sedation could join us, the special interest group on the ASPA forum, and you could use this QR code to join us there. Thank you so much for your patient listening. Goodbye. Bye-bye. Thank you.